Well, once again, good morning, everybody. This is Christian with Advantage Medical Testing. Today we're going to be talking about the Woman's Health Panel, Series 2 of our Retail Panel Series, Presentation 2, rather. This is a very important panel. Most women aren't even aware of all the issues that they deal with. I know they're aware of some and a lot, maybe most. But we're going to discuss why this health panel is so very, very important. We're going to build off of the last presentation, so we're not going to go over all of the basic terminology that we did before. Just remember that each of our genes have dominant and recessive alleles or characteristics that will come into play here later when we examine the report. First off is, who needs this panel? Well, pretty much all women who desire hormone therapy or are interested in overall health. If they want to know what's going on with their body, any woman should get this panel. It's really important for prenatal care, and especially if there's a personal or family history of insulin resistance or PCOS. And if you have questions about any of these definitions of these terms, we can get together after. But just for those of you that don't know, PCOS is polycystic ovary syndrome. This is also important for people for gestational or type 2 diabetes, and also females that have a personal or family history of cancer. It's important, again, for this personal or family history of what we just stated, and hypothyroidism, hormonal regulation issues, weight loss or weight gain issues, estrogen dominance, and endometriosis. Now, endometriosis, of course, is when the skin or tissue that normally lives inside of the uterus starts to grow outside of the uterus. And again, you can just imagine the problems that could cause. Also for women that are worried about hair loss, infertility, or preeclampsia. Preeclampsia, again, that's probably one of the most critical things that they look at during a woman's pregnancy. It shows up sometimes around, most of the time, usually around 20 weeks of the pregnancy. It shows up with symptoms of high blood pressure, and it usually means that there could be trouble with the kidney and liver. And if you have issues with those major organs during a pregnancy, that could turn very, very serious very, very quickly and kill both the mother and the baby. Thrombosis, stroke, and heart attacks, inflammatory disorders. So the Women's Health Panel studies 27 SNPs. And if you remember the terminology for that, single nucleotide polymorphisms, basically a mutation in the genetic code. These are the 6 areas that the panel focuses on that will cover all those things we just listed in the previous slide. It's going to focus on the methylation of folate, B12. And again, folate, or folic acid, you might know it as, it's probably the most important acid that the body has to deal with. It's a form of vitamin B. It's actually B9. And it's basically, without folic acid, you can't make red blood cells. It's a basic building block of anything that's genetic in our bodies. It's going to focus on clot risk, hormone risk and effects, metabolic risk factors, risk of hypertension, and also focuses on vitamin D. Again, vitamin D is going to be important. We'll discuss that here too. So let's talk about the methylation. Well, the methylation SNPs is going to deal with the FOLR1 and 2, the MTHFD, and the MTHFR. So the FOLR1 and 2 genes are basically responsible for transporting that folic acid, or folate, vitamin B, into the cells. And you remember, without folic acid being properly introduced into our body, converted to vitamin B, we just can't continue to live, really. I mean, it builds our blood cells, replaces them. Now, the MTHFD gene, these 3 genes are probably the ones that most people have heard about. The MTHFD, when that converts tetrahydrofolate and methyl tetrahydrofolate to methylene tetrahydrofolate. And so I could just keep reading this to you, but these three genes right here basically are handling the hydrofolates in the body. It talks about how that's being transported, processed, and absorbed. So again, the reason why these genes are so important to study is because without the proper absorption of vitamin B, which is probably the most important vitamin that we could take or process, it needs to be absorbed properly. Now, here's something that's kind of cool. As the woman ages, she needs more of this methylated vitamin B than when she is younger. Interesting. So if there's issues with these genes, of course, the common sense therapy would be to, include a methylated B12. It's the closest thing to B9 that we can make without it in the body. The second part of the test is going to focus on the clot risks. Now, these risks are created, okay? They're usually man-made created risk factors when we try to take control of our body with prescriptions, hormone replacement, and taking birth control pills. So we, as humans, are actually creating the clot risk because of these things. Now, it's important to control the clot risk because clots can be an issue when a woman's pregnant, and it typically can happen when the baby moves around and starts pushing on those blood vessels. They're more likely to get clots. Clots will stop the blood flow. Blood flow stops the oxygen flow to the brain, can kill the baby and the mother. We're also going to look at this factor 5 thing, the factor 5 laden they call it, but it's layman factor 5 and factor 10. And they look at these two genes because if there's problems with these, there's a higher risk of DVTs or thrombosis, placental separation, preeclampsia, and miscarriage. Again, we talked about preeclampsia. It's a killer. Now, as the woman ages, she needs more of these of methylated folates than when she is younger. And so what they'll do to help increase that is they'll sometimes try to give them more estrogen. Now, it's very, very important that they do not give the older woman more estrogen than she needs. Estrogen, too much of it in the woman's body, can actually cause cancer. So there's other SNPs that they study here for vitamin A and the lipid transport and estrogen production, breast and ovarian cancers. The hormone-related SNPs, we've got the FSHR. That's basically the follicle-stimulating hormone receptor. And so if there's problems here, the woman's unable to stimulate the follicles, which indicates that there's not enough estrogen. And again, estrogen is a very, very critical hormone for the female, especially if they want to have children. It deals with ovary development. And it's also, if there's issues with this gene, it's directly related to PCOS. They also study the CYP19A1, and that's going to relate to how testosterone is converted into estrogen. And what usually happens with testosterone, okay, it's a guy hormone typically, right? But females also have it, and in some cases, if a woman has she's normally healthy, but just has this feeling of not being well, can't put her finger on it kind of a thing, maybe feel a little depressed, just lack of energy, just a yuck feeling, right? I'm sure some of you know someone who's ever had that. So what the doctor will sometimes do is give them a prescription for testosterone pellets. And that's right, they'll give them guy hormones. And so what will end up happening is they start to feel better. They start to feel, more energy, and they start to feel, hey, I'm feeling great. But then all of a sudden, they may get problems because now they've got too much testosterone in their system. Now, the HSD3B2 gene, this is relating to all the ketosteroid hormones, and that's important because we just talked about introducing testosterone in the body. There's got to be a way to break that down. And so these ketosteroids, that's what breaks down that testosterone so it can be converted into estrogen. And when there's too much testosterone in the body, the woman may feel, tenderness in the breasts. And again, to get back that general unwell feeling. And then it can also account for some endometriosis. Now, the HSD3B2, if that's not working, it actually can give you an increased risk of adrenal insufficiency. And so if somebody has problems with this gene, they're going to have other things that are going on in their life, and so there's going to have to be a significant treatment plan there. I mean, a very aggressive hormone therapy, especially if they're pregnant, so they don't lose the baby. Now, the next gene they look at is the SRD5A, and that's going to relate to the testosterone conversion to DHT, and that's the dihydrotetro, the big words. It escapes me. But anyway, it's going to be relating to the conversion of testosterone into estrogen. Therapies include estrogen therapy caution. So if there's problems with any of these genes, especially if there's an overproduction of estrogen, can be very dangerous. So what they'll do sometimes is if a woman has too much in her system that's not getting too much testosterone is not getting processed correctly, so what they'll do is they may actually locally treat an area with a cream that has some estrogen in it if the body's not producing enough or too much and they can't control it. So they'll actually hand the woman a tube and say, here, rub this on your areas. Now, the other SNP studied for the vitamin A and lipid transport, again, that was a copy from the last slide. All right. We're going to talk about metabolic risk factors. I know some of this may be dry and with these genes, but it's very interesting because we're going to put it all together here in just a few minutes to show how the report will actually make sense to the doctor and the patient. Another gene is the FOXY1 gene, and this is directly relating to the thyroid hormone production. So if there's issues with this gene, somebody can actually have problems with their thyroid, typically hypothyroidism. ATG5, 12, and 16L1. Now, these are the autophagy genes. We talked about that in the last presentation. Autophagy relates to the cellular level detoxification and how it kind of recycles proteins and gets rid of the garbage at the cellular level. This also will indicate if there's issues here. Insulin resistance. And insulin resistance, it's a very, very big deal, especially for the people that are obese, risk for type 2 diabetes, because they have found a direct correlation to, and I'm not talking about the person that just eats and eats and eats and they do it to themselves. I'm talking about the people that actually try to eat right, and they still can't lose the weight, and they're the ones that are always trying the fad diets because nothing seems to work. They work out like crazy. They can't lose the weight, or they'll lose 2 or 3 pounds and they gain it all back. Well, in that situation, almost 100% of the time when someone has that problem, it's directly related to their body's inability to deal with insulin. So problems with these autophagy genes can cause all kinds of things. One of them is a gestational diabetes, type 2 diabetes. Again, this PCOS that keeps popping up, and here's a big one. I actually have someone that I know very well, has this fatty liver disease. The good news, though, is that if there's problems with these genes right here, this is probably the easiest to treat mutation. It's easily treatable. For example, they may give you some metformin, all right? Again, obesity is directly associated with the insulin-resistant issues. The next part of the panel that's discussed is the hypertension risk, SNPs, and the ACE and the AGT. And it's just interesting. Our bodies are a very complex machine, as you all know, okay? And as much as we all think we know, none of us know all of it. But they have found some really cool things about the body, and they've studied these things for years and years. And here's what they found out, okay? Your blood pressure is actually controlled by enzymes that are produced in your lungs and in your liver. So from your liver comes the bottom one, the angiotensinogen, and that is an enzyme produced in the liver. And then that gets converted into this angiotensin. That angiotensin is actually the device to control and regulate blood pressure. So we get this angiotensin from two places. Again, we get it from our lungs and our liver. So if we have problems with the ACE gene or the AGT gene, that's definitely going to be an issue. Again, hypertension, preeclampsia. Remember, preeclampsia presents with high blood pressure. And also, a biggie here, cardiovascular diseases. So it's interesting how we have two different systems here that are actually working together to regulate our blood pressure. Pretty interesting stuff. Vitamin D, SNPs. Okay, the VDR-TAC. This is basically the vitamin D receptor gene. And vitamin D comes from the sun, right? It also absorbs, it controls the process of taking and absorbing calcium to build strong bones. So people with osteoporosis, brittle, soft bones, as they get older, it's because they have usually the calcium's disappearing, and they have problems with their vitamin D. So vitamin D also, people don't know this, but it really affects a lot of other things. It affects your nervous system. Now, this is the ability to actually send and receive messages. So you may have people with a vitamin that present that they have some stroke-like symptoms because they have numbness or they can't, control their bodies. But it could be as simple as getting some vitamin D into the body more. Now, the GC or DVP, this is the vitamin D binding protein gene. Now, here's the thing. It's a two-part thing. These genes work together. You can swallow a whole bottle of vitamin D right now. And if your body isn't absorbing it or processing it correctly, that doesn't do any good. So you'll see people actually taking many, many vitamin D pills, but they may end up finding out if they take these tests and take them to their doctor, the results, that they don't have a problem absorbing or ingesting the vitamin D, absorbing it. They have a problem with their body binding that vitamin D so that way it can be transported, to where it needs to get transported to in the bloodstream. So in order for the vitamin D to move through the bloodstream, it has to be bound to those cells. And the way that's done is with a protein that's produced in the GC. So I know that was dry, so we're going to get to the report now, like we usually do at the end of these. So again, this is what the report will look like. It'll come, this is again, de-identified data. Talks about the session number, when it was collected, when it was received, who the provider, blah, 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 okay? Now, those of you who've seen this before, I got to caution you because, like I said, at the end of the report is a summary that the person can read and say, hey, these are some issues, you should get them checked out, blah, 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 take them to the doctor. But this is why it's important for the doctor to actually look at the results here. All right, so we're going to take a look at this thing. Now, right here, remember we talked about how green is good usually, and tan is the heterozygous result, and the heterozygous, just to refresh you, is the recessive gene, which means they may have gotten a dominant gene for this, or a recessive gene for this. And so there's a possibility they could get it in a dominant gene. This homozygous result means that they've got two dominant alleles. Okay, that means that, and this is pretty much a guarantee that they're going to present with these issues. This is a maybe. This is yes. This is nothing to really worry about. Now, nothing to really worry about for certain genes in a section where it talks about the vitamin conversion and delivery, for example, the first section here. See, we've got some greens here. So we don't have any issues with the FOLR1, but we have a recessive, a heterozygous result, which means they have a dominant and a recessive gene characteristic for FOLR2 mutation. That's tan, and so the next one's also tan. So as a layman or the patient will look at this and perhaps say, oh, I'm good to go here, but except for here. So just by taking the recommended therapies, I should be okay. Well, I can tell you something here. This person here, even though there's only red here, with these issues, they actually, the doctor, when they read this, will know because there's a formula that they use. And this person has basically a reduction in the processing of this vitamin B so much that it's down to 45%. Now, women over 50, for example, they need to have at least 50% or higher absorption. Okay, so this will tell them that even though these are good, this red kind of pulls these into the equation and it drops them down to a 45% absorption rate. We don't go over those formulas, but that's what this is. That's why the doctor is critical in interpreting this. Okay. So then it looks like we've got another red down here, and again, we talked about before, it gives you a basically a medication or a chemical solution to some issues, and some more here, methylfolate plus. Again, it makes sense, right? They're not able to transport this methylated material, so they need help, and they need more of it, so they will give them some methylated vitamin B, and I talk about methylated vitamin B a lot. All right, so the second section is the clot risk section. Okay. Oop, lost control. All right, so it looks like in the clot risk section, we don't have any heterozygous mutation or homozygous mutation results, so looks like we're all green. So in this particular situation, they are all good. The estrogen metabolism and clearance, this is another part of the report. The CYP1B looks like it's got the hetero, which means it's a possibility that they may have some problems. Now, so right here it looks like there's a possibility, right? But what a doctor will discover is that because of this this increased ability to produce estrogen, they actually have a red here for this gene. So what you don't know and what I don't know unless I look it up, and what the patient won't know is even though this is the hetero result, because of this particular gene having the homo result, they are guaranteed to produce more estrogen than they need, which could cause cancer. Okay? That's a definite. So, and if she needed, again, even though she's producing too much estrogen internally, if she needed estrogen in the future, they wouldn't give her pills, they would give her a cream. It doesn't make any sense why they would give you estrogen if you had too much in your body, but it just didn't get to the right places. All right, so we're going to go down to the FSHR gene. So this basically is going to tell the person that she's got a huge high risk, a higher risk than normal of PCOS. And because of that, if the thing isn't caught in time, they may not be able to get pregnant because of this gene mutation. Then we're going to go down to the next one. Looks like we have the CYP19A1, endometriosis, high risk. So you can see the treatments that they're providing recommendations for. They're also, remember, recommending different tests or more tests, and some lifestyle choices, recommendations. Back here we've got our autophagy genes. Remember the autophagy gene? So it looks like we have some issues with autophagy, and so then they'll look at, again, some metformin to possibly help with that absorption of those important vitamins and minerals. Look at the treatments. Look at them all. All right. And so down here we've got the hypertension risk. So these are, again, heteros, so they're not a red flag, but there's something definitely that they need to look into. And again, the vitamin D. So it looks like they have problems, perhaps, with their vitamin D. Again, this might be the person that is taking vitamin D like it's going out of style. And so they're going to recommend some therapies here. So at the end, you're going to get a summary for the report, and this is going to just basically tell us what all of those last 4 pages told us in a simple narrated form. So here's the thing. If they don't want to get into what genes what, this is what they're going to look at and talk to their doctor about. Hey, doctor, I got this report, and here's what they found out. The doctor will take it, and it looks like they're going to be recommended, again, the methylated B and folate. Look at all these things that are recommended in the therapies. And here's some provider discretion ones. This is just some ideas to toss at the doctor. Hey, look, you may want to try this or try that. Lifestyle recommendations. Look at this. Be cautious with high-dose estrogen birth control or estrogen supplementation due to increased production of the 4-OH estrogen metabolites. So if you have somebody that's taking this that's on birth control and they get this report, they may want to seriously look at talking to their doctor soon so they don't cause their body any more damage than they might have already done. And also look for the PCOS. And they also may need supplemental progesterone during pregnancy. Testosterone therapy may produce higher levels of estrogen. They also have an increased risk of insulin resistance, gestational diabetes. So then here's some dietary recommendations. And then here's some more recommendations to the lab. Consider giving her some more vitamin D. Check out the insulin. Take it easy on the blood sugars for a bit. Look at those tests for testosterone, progesterone. All right. So I'm going to go ahead and stop the recording.